Welcome to session 40 in the online Falcon Review series on anatomy, and now we're going to discuss the autonomics of the head and neck. Let's start with a question first. A 48-year-old man presents with a constricted right pupil, which does not react to change in light intensity. His left pupil and vision in both eyes are normal. These findings are most likely due to a lesion involving which structure on the right? What you can tell from this stem is the key is the constricted right pupil. And a constriction of a pupil means that the parasympathetics are unopposed. That means that the sympathetics have been lost. If you look at the options in this one and simply pick the one answer that is sympathetic, then you would have the answer, the superior cervical ganglia, B. The superior salivatory nucleus is associated with salivation, of course. The nervus intermedius is going to be associated with 7, and the Edinger-Westphal nucleus is going to be the parasympathetic component of cranial nerve 3, whereas the trigeminal ganglia is a sensory ganglia altogether and not even autonomic. If we look at this picture of the autonomics, it can be a little bit intimidating, but if we look and break it down, the sympathetics are really the thoracolumbar outflow, and they're going to come from T1 to L2. Then all of the sympathetics need to get into the sympathetic chain, which is paravertebral, and then the parasympathetics are involved in coming out in two places. There's the cranial outflow from the cat nerves, cranial nerves 3, 7, 9, and 10, and then there's going to be a distribution of 3, 7, and 9 to the head, whereas 10, the vagus, coming from the term vagabond, is going to be the wanderer that will go from neck all the way to the hindgut. The parasympathetic sacral outflow I oftentimes refer to as the poopers, because the S2, 3, 4 will push poop on the floor, because that's going to go to the hindgut, which will control the rectum. Then we've already talked about our abdominal preaortic ganglia, and now we're going to move up into the neck and talk about the cervical chain ganglia, which are really just a large version of the cervical of the chain ganglia that we've seen in other locations. And we'll also have the parasympathetics, which will have 4 paired ganglia in the head. And this will be the first time that you'll be actually able to see a focal ganglia, because in the rest of the body these tended to be diffuse in nature. Let's start with the sympathetics of the neck. Here you can see the sympathetic chain. And the sympathetic chain has 3 primary ganglia associated with them along the neck. There's the inferior cervical ganglia, which sometimes connects with the first thoracic ganglia to make the stellate. Then there's a middle cervical ganglia, which is variable, and there's a great big huge superior cervical ganglia, which usually spans from C1 to C3, all the way down to the bifurcation of the carotid in many cases. This is like the last synapse opportunity until you get into the head. Therefore, all of the axons that are going to be going to targets within the head have to synapse at that superior cervical ganglia. They'll have postganglionics coming off and running with the vessels, because the vessels are what they're largely going to be responsible for supplying. That's called the carotid nerve. And then running off of those areas down into the heart regions, we have some descending cardiac nerves. Notice that the vagus nerve is coming out and running in the carotid sheath at this level, and has a couple ganglia associated with it here as well. So what's happening with the sympathetic trunk and ganglia of the neck? They lie posterior to the carotid sheath on the prevertebral fascia and not in the carotid sheath itself like the vagus nerve. They have a superior cervical ganglia, and those are going to run along and run from C1 through C2 or even C3 vertebrae. Then they're going to travel into the cranial vault, largely on vessels via the carotid nerves. and that's going to form a carotid plexus, which will distribute all over the vessels of the brain. The middle cervical ganglia is going to give rise to the middle cardiac nerves towards the cardiac plexus in the thorax, and then the inferior cervical ganglia will give rise to the inferior cardiac nerves of the cardiac plexus, which will also fuse to the first thoracic ganglia to form the stellate. Here we can see a Horner syndrome. Indeed, this is a congenital Horner syndrome, and there's a couple ways that we can clue into that based on the presentation. It has a typical presentation with a slight variation. There is a partial ptosis associated with Horner syndromes because of the small amount of smooth muscle that loses its innervation when the sympathetics are taken out on one side or the other. This particular person doesn't really show much of a partial ptosis because they were actually born with this congenital Horner syndrome, and the muscles that elevate their eye have had opportunities to compensate for that lack of the smooth muscle. Here you can see a ptosis of someone that is not Horner syndrome related, but the lack of muscle for their levator palpebrae superioris from cranial nerve 3 being affected. The other features of a Horner syndrome are going to be anhidrosis, meiosis, pupillary constriction, vasodilation or flushing, and in this person we also have heterochromic iridis, which means that the one eye that's been affected also has the less pigmentation cells in the cornea. Now, one of the reasons that this is suspected to have a congenital Horner's is because there's been a migratory problem with the neural crest cells, which also affects the epithelial cells in the eye, causing the pigmentation. Let's go to another question. A 62-year-old female presents with unilateral dryness of the nasal cavity and paranasal sinuses, loss of lacrimation, and a decreased salivation. Which structure do you suspect has been injured? This would have to be the superior salivatory nucleus. To take out both the eye's dryness as well as the paranasal sinuses in all the different areas and lacrimation and salivation, the only thing that has been taken out is the superior salivatory nucleus, which would be associated with cranial nerve 7. The ciliary ganglia is for taste. The pterygopalatine ganglia is only one area of this injury, and we'd have to knock out more than that, so we have to look more towards the central nervous system. Now let's look at the general patterns of the parasympathetics of the head and neck. What we have is cranial nerves 3, 7, and 9, which will all have ganglia that they'll project to, but they'll also have nuclei in the midbrain, pons, and medulla. The Edinger-Westphal associated with cranial nerve 3 nucleus is going to be in the midbrain. Cranial nerve 7, the superior salivatory nucleus that we just discussed in the previous question, is going to be in the pons, and then the inferior salivatory nucleus, because it's associated with cranial nerve 9, is in the rostral medulla. Now, these three nerves will have preganglionic axons that will come out, and they'll go to a peripheral ganglia in the head, and then they'll be distributing on postganglionics, which happen to be sensory branches of cranial nerve 5. They follow those out because they're trying to get to the same locations as those branches are distributing to get to their targets. Their targets are the same as that we've always seen with autonomics, either smooth muscle, glands, or cardiac muscle. Of course, there's no cardiac muscle in the head, so these are going to be smooth muscle and glands that are being supplied by parasympathetics of the head. And they'll be coming off with the cranial nerve 10 that has vagal nuclei, which would be the dorsal vagal nucleus and the nucleus ambiguus, and those will distribute all the way down to the splenic flexure, as you recall, but we're going to leave that one alone because we've talked about it significantly already. let's turn our attention to the four paired parasympathetic ganglia. They are located in the orbit, which is the ciliary ganglia, the pterygopalatine fossa, which is the pterygopalatine ganglia, the paralingual space, which is known as the submandibular ganglia, and finally in the infratemporal fossa, which is known as the otic ganglia. All of those will have the distribution as we've discussed earlier. Cranial nerve 3 will have visceromotor branches that will go to the ciliary ganglia in the orbit, and it will follow V1 patterns to distribute out to the various targets inside the globe of the eye. And they'll be going to the ciliary muscles and the pupillary constrictor muscles. Cranial nerve 7 has two associated ganglia. There's the greater petrosal nerve that will head out to the pterygopalatine fossa. That will distribute into the V2 distribution zone of the midface, so it'll be going to nasal and palatal glands. It will also send a branch up to get to the lacrimal gland because the ciliary nerve does not do glands. That communicating branch will head up on the lateral side of the orbit. Then cranial nerve 7 has a second nerve that will come off of it, chorda tympani. That will go to the submandibular ganglia, which will then distribute with branches of V3. The lingual nerve specifically, as it goes towards the glands of the oral cavity, including the sublingual and the submandibular. Finally, the fourth paired nuclei will be coming from cranial nerve 9, the lesser petrosal. That will become from the inferior salivary nucleus. Then it will go to the ganglia in the infratemporal fossa, the otic ganglia, and again it will distribute with V3's sensory branches. More specifically, it will distribute on the auriculotemporal, which will be carrying sensation to the parotid gland, and it's this lesser petrosal from 9 that will go on this nerve and supply the parasympathetics to the parotid gland.